Hello. Hi, can everyone hear me? My name's Cathryn Lee. I'm a faculty member at the University of Chicago in the section of Pulmonary and Critical Care. So my research and clinical interests mostly revolve around interstitial lung disease in general in the pulmonary clinic. But I'm here to talk to you specifically, obviously, about scleroderma and its wide variety of lung manifestations. All right. So when we think about how the lungs can be affected in a wide variety of autoimmune diseases, not just scleroderma, it can be manifest in a wide variety of ways. It's often under-recognized, as Dr. Vigneswaran alluded to. A lot of times the symptoms of lung diseases and scleroderma are cough and shortness of breath, which can be from a wide variety of things, not just lung disease related to your autoimmune disease. Interestingly, it might not always track with the rest of the rheumatologic symptoms in scleroderma and in other disease processes. So, for instance, even if you're having joint symptoms or swallowing symptoms or lack thereof, doesn't mean that you're not going to have lung symptoms as another time. It can obviously impair your quality of life if you have, lung disease and aren't able to breathe because of your scleroderma. Oftentimes when patients first come to my clinic, they haven't been diagnosed with any autoimmune disease yet, and they're having symptoms of cough and shortness of breath. And this can be from and they might go to a GP or another pulmonologist and not even know that they have an autoimmune disease. And this can happen for a wide variety of reasons. One is that, again, the presentations can be different. Different patients can have different symptoms or no symptoms at all. Interestingly, the lungs are oftentimes the first manifestation of an autoimmune disease, in particular scleroderma. And this, I tell my patients, it's like because the lungs are the first organ to see a lot of the environment, they're really immunologically active compared to a lot of other organs in our body. And so sometimes autoimmune disease can first manifest itself in the lungs itself. And so when it does this, we call this either lung dominant disease or lung limited disease. And importantly, scleroderma, interstitial lung disease, and a wide variety of autoimmune lung diseases are treatable, especially compared to other disease subtypes that don't have any underlying known cause. So when I see patients in clinic with autoimmune disease, and I think they might have a lung complication, there are a few different tests that I like to order to try and figure out, is this, scleroderma, or is this another type of autoimmune disease? And so just to give you a sense of how we're diagnosing scleroderma versus some of these others. So the first thing that we often order in pulmonary clinic is actually a series of blood works, a series of lab tests that look at various antibodies. And some of you might have had these, including the SCL-70 antibody or the centromere antibody or the ANA. And if these are positive, that it can more likely suggest scleroderma as opposed to some of these other underlying diagnoses. Another thing that I often do is something called a high-resolution CT scan or a CAT scan of the lungs. I don't know if some of you have had that before. But basically what that does is it gives a really detailed assessment of the lungs and how the lungs look and helps tell me, is there involvement of the lungs related to the scleroderma or other autoimmune disease? And if there is, how much of the lung is involved? And generally, when we say more than 10% of the lung is involved, that's when it usually reaches the level of calling it a lung disease or an interstitial lung disease. Something else that we're often wondering about, not only scleroderma patients, but all other autoimmune disorders is there pulmonary hypertension involved? And so we'll get into the manifestations of this and what this is, but pulmonary hypertension is high blood pressure in the lungs, just like you can have high blood pressure the rest of your body. And in a lot of other autoimmune diseases, that pulmonary hypertension, if it's present, is from the lung disease itself. Basically, the strain and the inflammation and the scarring of the lungs kind of puts strain on the heart and causes that pulmonary hypertension. Scleroderma is kind of unique in that patients can have pulmonary hypertension without having other disease involvement in their lungs. And that might affect treatment down the line and how you're evaluating for it. And I'll talk to that in a little bit. And another important point that we think about when we're thinking about how is the lung involved in all these different connective tissue diseases is there involvement of the pleura? The pleura is basically the lining around the lung. And it can cause, either cause chest pain or like pain with breathing if you have inflammation of that lining of the lung, or it can also cause fluid around the lung. And so in the case of scleroderma, pleural disease is actually fairly uncommon. And I'm not saying it never happens, but when it is present, sometimes you think about, is there something else going on? Or is there either another autoimmune disorder or another type of, medical comorbidity or medical problem that's going on? All right. So the lung manifestations of scleroderma are myriad. As already mentioned by Dr. Vigneswaran in depth, so I'm not going to go into it, but aspiration or esophageal dysmotility not only affects obviously the esophagus and the symptoms there, but can also affect the lungs, including cough, shortness of breath. And sometimes you can even see abnormalities in images based on this aspiration that occurs. So interstitial lung disease. So, this says over, half of cases is something that we generally quote. I don't want to scare anyone and think that literally over half of people with scleroderma have interstitial lung disease, but rather, in the people who happen to get CAT scans for whatever reason, in about half of them, maybe more, we sometimes find these abnormalities that are associated with interstitial lung disease. It oftentimes doesn't reach the level of, affecting how you breathe or progression or anything like that, but it's often sometimes something that we're seeing, and we're trying to sort out, not just in scleroderma, but in a wide variety of lung diseases. When does this progress? When does it not? We're still working out on that in a research capacity. Pulmonary hypertension, as I mentioned, can occur in about 8 to 12% of patients as well. You can rarely, again, pleural involvement can be present, and then rarely you can get lung cancer. I don't think the risk is generally that much different from the general population in scleroderma. It just happens in a slightly different way. All right. So, this alphabet soup, as we like to call it, of interstitial lung disease, because we oftentimes have so many acronyms. I know all of medicine does, but even within medical specialties, people make fun of the interstitial lung disease specialists because of the number of acronyms that we have, and they call us the alphabet soup doctors. So within this alphabet soup of interstitial lung disease, what are we going to talk about today as far as, what things are currently being done? And so the first, we're going to talk about the diagnosis, treatment, and monitoring for patients with interstitial lung disease. And then we're going to briefly talk, even though I'm not a pulmonary hypertension specialist, and depending on what center you go to, that might be more of a cardiology domain versus a pulmonary domain. At the University of Chicago, there's 2 cardiologists that I work closely with, and we have meetings together about these patients. But we're briefly going to discuss the diagnosis, therapies, and monitoring of pulmonary hypertension as well. All right. So when we think about scleroderma and its overall diagnosis, and when a patient comes to me with lung disease and I'm trying to figure out, is it related to scleroderma or not, the diagnosis can be unclear, as I'm sure many of you have appreciated. Now, this chart is too small to actually read. It's just the point being the fact that there's lots of different ways that people can ultimately be diagnosed with scleroderma. And basically, there's a point system. I don't know if you've heard about this, but back in 2013, when they made this criteria, they made it, if you have 9 points or more, then you have scleroderma. But if you look at these different criteria, the only one that you can qualify that is worth 9 points alone is having skin thickening that's beyond your fingers, basically. If you have that, then you have scleroderma, regardless of these other tests, most likely. But oftentimes, I'm seeing patients that have a little bit of here, a little bit of there, and we're trying to figure out, okay, do they have scleroderma? And kind of relating to this point, so this patient actually was someone that was seen by our group at University of Chicago, and they were told that they had idiopathic pulmonary fibrosis, which is another lung disease with very different treatment options compared to scleroderma. But when my colleague saw her in clinic, she noticed that she had skin thickening that was going all the way up her hands. And so, I guess what I'm trying to say here is that some of these exam findings can be relatively subtle. And when in doubt, as a physician, none of us mind, at least I don't mind, when other people go and grab a second opinion somewhere else just to make sure that people aren't missing anything, because we're all human. But basically, this person ended up having, was initially diagnosed with idiopathic pulmonary fibrosis, came to our center, was ultimately diagnosed with scleroderma, and is now doing well on treatment directed at her scleroderma. All right. So, there's a lot of different factors. When people say to me, okay, well, why did this happen to me? Or what's the underlying cause of this scleroderma and the scleroderma lung disease? And the short answer is we're not quite sure yet, and the long answer in terms of where research is right now is that we think that a lot of these autoimmune related lung diseases, and in particular scleroderma, are related to this cycle of injury that occurs in the lungs, followed by repair that's not quite right in the lungs. And it leads to this vicious cycle of getting scarring when in normal lungs you would get healing after a particular injury. Now, what would that injury be? And part of my research is figuring out that there's a wide variety of different exposures that have been related to interstitial lung disease. And so our overall thought is that there's probably some form of genetics that's involved, whether it be a genetic mutation. There's not a lot that we know about in scleroderma, but there's definitely some, disease that runs in families, or some innate susceptibility that patients have for whatever reason. They have some sort of exposure risk, whether it be an occupational exposure, which we'll go into, whether it be a random virus, which or some other type of infectious syndrome. And then they have an aberrant immune response for whatever reason that, again, we're still figuring out what those things are. And those three things converge to determine a patient's overall disease course. And so part of my work and others is not only trying to develop effective treatments, but figure out how can we stop this disease course from happening in the first place, and how can we identify people who are more at risk for this disease in the first place for better screening of people who are more at risk. All right, and so there's some ideas out there that scleroderma, particularly in a subset of patients, could be an inhalational injury. And actually, one of the very first descriptions of scleroderma lung disease was actually at the turn of the 20th century in stonemasons in Scotland. They actually noticed that there were a lot of people having some lung diseases from there, and that's how those patients were initially diagnosed with scleroderma. So again, we think that there's a susceptible host. They might get exposed to something and then have autoantibody formation, particularly those autoantibodies that were on that list before, including things like SCL70, RNA polymerase 3, and then they can develop scleroderma with or without interstitial lung disease. And so some occupations that have been associated with scleroderma include things like sandblasting, stone fabrication, things in the metal industry and steel mills, bricklayers, so lots of different concrete and silica are the main exposure that has been implicated, but there's more that we're discovering as there's more and more novel exposures that just occur with industrialization, globalization, et cetera, et cetera. All right, so just a deep dive real quick into some of these. So there was a case control study by a group in Canada in the mid-2010s that noted that they basically compared 100 patients with scleroderma, and they compared them to 300 people who were around the same age, the same sex, and also were smoked cigarettes. Because as you might imagine, things like cigarette smoking also kind of go hand in hand, not only with interstitial lung disease, but with some of these other exposures. And they found that a lot of these exposures differed by gender. So for instance, in our clinic, and multiple clinical cohorts have shown that if you have a connective tissue disease and you're a man, you're more at risk of having these interstitial lung diseases, particularly related to these occupational exposures. And they're the same occupational exposures I listed on the prior slide. Interestingly, there's also some thought that maybe some occupational lung disease is misdiagnosed and is really actually autoimmune lung disease, or autoimmune, in particular scleroderma. So for instance, they looked at 40 cases of pulmonary silicosis and then found, which is basically, it's like black lung or coal miner's lung, but in the case of silica, and they found that about a fifth of them, when they went back and looked through things, had some sort of autoimmune disease, including scleroderma. And this is just a case example of a patient's hands in this case. And so in terms of emerging occupations, so this is what I'm talking about in terms of as we develop new techniques for manufacturing, we're finding more and more associations with novel exposures and lung disease. And so this is a case series. There's been a couple case series right before COVID, actually, where they found that stone fabricators. So these are people who make the artificial stone that's found on your kitchen countertop. and because they're grinding it up in order to like put it down, and they had an increased rate of silicosis, sometimes requiring things like lung transplant. But the important thing about this is it's totally preventable. Like even something as simple as wetting down that stone before you grind it, like severely reduces the dust. And they found a lot less cases after this has been a requirement in occupational settings like this. All right. So getting back to the manifestations of lung disease specifically. So why does interstitial lung disease happen? And it's thought that this inflammation that occurs in the setting of scleroderma activates fibroblasts, which are cells that sit in the lung and literally create scar. And a lot of patients, they can create scar and then they go away. In healthy patients, they create scar and go away in patients without disease. But in patients who have aberrancy in this pathway for whatever reason, they can get more scar deposition and create that vicious cycle I was talking about to begin with. When we look at CT chests of patients with scleroderma, and again, this isn't just all comers, this isn't people who are in research studies, so the proportion's going to look higher. Up to 90% can have some sort of abnormality on CT chest. When they look at those patients with the abnormalities on the CT chest, about half of them have some sort of abnormality in pulmonary function. I talked about the antibodies. There are different antibodies that are associated with interstitial lung disease in particular. And when you look at it compared to idiopathic disease, patients with interstitial lung disease and scleroderma have a much better survival, actually, compared to the other varieties of interstitial lung diseases that we see. When we talk about pulmonary hypertension, it can cause injury to basically the inside of your artery, just like it can cause injury to your lung. And we find that it occurs again in anywhere between 10 and 20% of patients overall. But if you look at the echocardiogram or the ultrasound results themselves and just don't take the patient into consideration at all, that number can be a little bit higher just in terms of like the random abnormalities that can be seen on ultrasound. It unfortunately is associated with worse survival overall when it occurs, which is why early detection is super important. So in Scleroderma-ILD, as we noted, it's noted in a majority of patients. Only about a fifth of them, however, become progressive. So a lot of patients just stay exactly the same over time, both because of treatment and because their disease is relatively minor. So the risk factors for progression in patients include being older age, being of non-white race, having the SCL antibody, being a man, actually, and having an early decline in FVC and DLCO. And that's the pulmonary function test metrics. And this is what I like to tell a lot of my patients is that, a lot of times in terms of, figuring out prognosis and figuring out how you're going to do, how you've done already the year prior really predicts better than anything else how you're going to do the next year, which is why I really advocate for frequent monitoring. And we'll go into the end of what I, recommend for patients with this manifestation of scleroderma, because as soon as you detect something, as soon as you detect a decline, there are treatments that can be offered. And so this is just a patient to explain kind of what we're dealing with in terms of our, better CT scan technology. So this is a patient that was diagnosed late, actually, but when we went back and looked at some CAT scans that were present like 20 years prior, she already had some small changes, and I'll go into the different types of CAT scans in a minute. And then in 2003, 4 years later, she had a few more changes, and then unfortunately she developed, worse disease. But a lot of this is preventable, and so that's why it's important that you're talking to your, rheumatologists and other doctors up front about, how are we screening to make sure that lung disease doesn't develop. So there's a few different manifestations on the CAT scan of the lung that I wanted to talk about just briefly. So first is nonspecific interstitial pneumonia, or NSIP. It's a member of the alphabet soup in terms of, the CAT scan patterns that we see. I personally hate this term because nonspecific interstitial pneumonia just doesn't really mean anything, and it's actually a very specific pattern. And the specific patterns that we're looking for are, is there a whole lot of inflammation? when I look at a CAT scan of patients with scleroderma or any other lung disease, my two main questions are how much inflammation is there and how much scarring is there? Because those two questions are going to lead me down two entirely different treatment pathways. So in terms of inflammation, so what I'm looking for here, just to orient everyone real quick. So if you haven't seen a CAT scan before, so this is a patient lying flat, and their head is pointed away from us and their feet are pointed towards us. So this is their right lung and this is their left lung. The black overall means air, right? So this is the windpipe just filled with air. The white is bone. So this is like your back and your ribs. And so this black are your lungs. Some of these dots are normal. So these big bright dots are just the blood vessels going into your lungs. And so the normal lung kind of looks like this, where it's mostly black here. The abnormal part, and so this is kind of subtle in this patient, are these like streaky gray opacities here. This is what's consistent with lung inflammation. And so this patient has not this non-specific interstitial pneumonia pattern that's associated with inflammation in scleroderma. And so there are treatments directed at the inflammation that we'll go into in a minute. So contrast that with this patient. So again, similar patient, this big thing is the heart. This is in a different slice of the lung. So this is a little bit further down in the lung so that you can see. And so you can see that there's a little more scarring here. And so this is fibrotic NSIP. Fibrotic and scarring just mean the same thing, by the way. So many of my patients are like, I have fibrotic disease, but someone else had scar. Which is it? And those are really just the same term. And so there's specific treatments directed at the scarring element of it that we also have. All right, so different treatment options. This is an overview, and we're going to go into them in a bit. So the original, years ago, in the early 2000s, the main drug that we had for scleroderma was something called cyclophosphamide. I don't know if any of you have been on it in the past, but basically, it's an IV medication. It has lots of side effects, including things like, low cell counts, you can actually have, bleeding in certain places. And so it's not used too much anymore. But the only reason I bring it up is that to this day, a lot of treatments are tested against the cyclophosphamide when you look at the trial. So if you're reading about a new drug and they were comparing it and saying it's non-inferior to cyclophosphamide or something like that, that basically just means compared to the old standard of care, this one's a little bit better. And I'll go into that in a little bit more detail in a minute. Mycophenolate mofetil is kind of our mainstay for scleroderma, interstitial lung disease. I don't know if any of you have been on that medication before, but we'll go into some of the data regarding that. But that's pretty much, I would say, standard of care for most scleroderma patients if they have when they have lung disease. Azathioprine and rituximab are some alternatives that you can use, either if you're not able to tolerate the mycophenolate well, and we'll go into what the side effects of that medication are, or if you if patients progress despite being on these medications. Stem cell transplant is a novel, therapy that people are starting to use for scleroderma. We don't offer at the University of Chicago, but I did just want to bring it up briefly because it is something that you can consider. I know the University of Pittsburgh, for instance, does it. And then some of our newer agents that we're using include tocilizumab and nintedanib, which I'm going to talk about briefly. All right. So mycophenolate mofetil, or CellCept. It's, as I mentioned, it's our mainstay for scleroderma-related lung disease. It's pretty well tolerated compared to other medications. It's potent. Basically, all of these medications act in some way on the synthesis of white blood cells. So it's basically targeting, in this case, it's targeting literally how the DNA is formed in these white blood cells in order to prevent them from attacking the rest of the body. Generally, we start at a dose of 500 milligrams twice daily, and I try and target a dose of 1,500 milligrams twice daily as long as the patient can tolerate it. The reason I bring that up is, personally, there's sometimes in terms of, overall, if you're not able to tolerate certain doses, but in general, I would say I try not to leave people on 500 twice daily for a long period of time, like years and years, because I just think that either you want to be on a more effective dose or try something else completely. The main side effects, and people in this room who've, experienced it, feel free to talk about this as well, but, diarrhea and GI upset are a main one with this medication. You can also get an increased risk of infections. There is with all immunosuppression, there's a theoretical risk of skin cancer. However, more recent data that we have in interstitial lung disease, and specifically, there was a big group in Canada who basically studied Canada has a system where they're able to just unify all their centers together and pool data. And so they looked at all the interstitial lung diseases or patients at all these centers in Canada and found that there was no increased risk of cancer overall in people on mycophenolate compared to people not on mycophenolate. If you do have GI side effects, there are some things we can do. So first off, we can decrease the dose. You can also try it in more frequent intervals, so like the same total daily dose, but 3 times a day. Or you can try Myfortic, which is an alternative regimen or an alternative formulation of mycophenolic acid. The things that we like to monitor in patients are blood counts. So we get CBCs every 3 months and metabolic panel. So this is measuring your kidney function and liver function every 3 months. And importantly, we avoid this medication during pregnancy because it is a teratogen. And also importantly, if you have any joint disease, it doesn't treat it. It's not super effective for joints. So this is what I was talking about where we're comparing everything to mycophenolate or to cyclophosphamide. So this is just showing that the main study that we have against this, you'll see that it was published in 2016, but most of the patients were actually enrolled much earlier, like in the early 2000s. And it was a randomized trial, which I will say, compared to other autoimmune lung diseases, I actually think that scleroderma has the best data and the most treatments for it. So there's a lot of these small randomized control trials looking at specific therapies. And they compared mycophenolate to cyclophosphamide. And this was in patients who, again, had to have scleroderma for less than 7 years. Someone else brought that up in the previous session or in the intro of, why that is. I think it has a lot to do in terms of a trial design perspective, that they're trying to make sure that everyone who's enrolling in the trial is around the same stages of their disease. Like, it's not helpful, I think, big pain. We need to do other trials, and we are doing other trials in the interstitial lung disease space where people are already on standard of care therapy for many years, and we're adding things on. But it's, I think that's the reasoning from a scientific perspective why a lot of the times that happens. These patients, compared to other trials that we'll look at later, actually had to have more significant disease. So they had to have significant dyspnea as well as significant findings on their pulmonary function testing. And they had to have that inflammation that I was talking about on those previous CT scans. And it found that it was just as good as cyclophosphamide. We'll go into the next slide. But this slide is actually just showing the time to first severe side effect and showing that the mycophenolate in this top line here was much better tolerated than this previous cyclophosphamide, which was previously the standard of care. And so, again, it found that patients their lung function actually improved, which is honestly, I always tell my patients, stable is good. Improved is excellent, but what we're aiming for is stable. So the fact that they were able to improve lung function really shows, how this potent anti-inflammatory mycophenolate is. And it, as you notice, has a lot fewer side effects. Only 4 people had adverse effects compared to 34 in the other group. All right, so then the other study I want to talk about is for this medication tocilizumab. I don't know if any of you have heard of this medication. So it's an IL-6 inhibitor. So it was originally studied mostly in skin scleroderma in early 2020. And so the patients in this study had to have skin scleroderma for less than 5 years. Interestingly, it kind of took the opposite approach to the previous study. So you could have lung disease, but they wanted people with actually less severe lung disease. And in fact, only 60% of them had lung disease at all. So this, was also studied in patients without lung disease with scleroderma. And interestingly, they were mainly looking to see if there was any change in the skin score, and they didn't find any change in the skin score. But what they did find in their secondary outcome was that that patient's lung function really stabilized or improved over time compared to patients who weren't on tocilizumab. So this is something that I consider in my scleroderma patients as well. All right, so that was a lot about the inflammation about scleroderma, but what can we do about patients who have scarring in scleroderma in their lungs? And so, scleroderma, again, there's no other, Scleroderma is the only autoimmune disease that has its own randomized clinical trial for this drug. This drug was studied in other autoimmune lung diseases altogether, but there was a separate study just looking at scleroderma in and of itself. And so this drug is called nintedanib or OFEV. I don't know if any of you have heard of it. But basically, it's a medication. To be fair, no one really knows exactly how it works, but basically, it affects the scar deposition into the lung. It doesn't reverse anything, but it prevents further scar from being formed. And so there was a randomized trial of this drug. Again, you had to have scleroderma for less than 7 years, but you had to have at least 10% scarring on your lung. So again, going back to how much inflammation is there, how much scarring is there, is a very important question that I think about in all my patients. And so they compared patients who were on OFEV or nintedanib. And importantly with this study, again, going back to like patient-centered trial design, they were allowed to take mycophenolate on top of it, which is important. Some of these earlier studies, you literally weren't allowed to be on anything else and the study drug. And so the fact that you were allowed to take other drugs, including mycophenolate, is important. And so what they found is that patients who weren't on any drug had a lung function decline. And the patients who were on this anti-scar drug had a lung function decline as well, but that decline was much less. And again, this, in terms of averages, so this is over the span of a year. So we're talking, 100 cc's a year, which in and of itself, 100 cc's in a year, I don't think is, it's maybe enough to be clinically significant, but it's kind of on the borderline. But it just goes to show that this is a very slowly progressive disease. And so we're showing that we're kind of altering the slope of that line and preventing further decline in lung function. All right, and then this was the other study I was talking about with nintedanib. So scleroderma patients were also allowed to be in this study, but made up a lot less of a percentage of the population because it wasn't everyone. In the census study that I just talked about, you didn't have to have lung progression before to be enrolled in the study, and in this one you did. So this to say that in scleroderma, you don't have to have have shown that your lungs are declining over time. You just have to show that there's enough scar there in order to qualify for this medication. So this was another study looking at nintedanib, and this also showed a pretty similar change in the rate of lung function decline. So again, lung function still declined, but it declined a lot less in patients who were on nintedanib versus placebo. All right, so that's interstitial lung disease. So briefly, I only have a few minutes. I just want to talk briefly about pulmonary hypertension. As I mentioned earlier, so pulmonary hypertension is high blood pressure in the lungs. In other patients, it's oftentimes related to the extent of your lung disease. So if you have severe lung disease, you might also have severe pulmonary hypertension, but that's not true in scleroderma patients. For some patients might have severe lung disease and have severe pulmonary hypertension, but patients in scleroderma are more likely to have pulmonary hypertension without having lung disease at all, or not enough lung disease to explain the level of their pulmonary hypertension. Risk factors for pulmonary hypertension include Raynaud's, having a limited skin scleroderma, and having the anti-centromere antibody. Pulmonary function tests also show a specific pattern in these patients. So when I'm reading pulmonary function tests, this particular pattern indicates to me that a patient might have pulmonary hypertension. It doesn't indicate what type of pulmonary hypertension, but it just might indicate the fact that they do have pulmonary hypertension. And then another important thing to note about pulmonary hypertension is that the echocardiogram, or the ultrasound of your heart, which some of you might have, it's a good screening tool to figure out whether or not some patients might have pulmonary hypertension or not, but it's not perfect. And some patients can still have pulmonary hypertension while having a normal echocardiogram, and some people can feel fine and have severe, disease on their ultrasound. So it's something that doesn't always track based on symptoms or severity. All right, and so this just goes to show, this is just kind of a diagram to look at why pulmonary hypertension can affect you. So basically, what first happens is that you have thickening of this blood vessel, which leads to kind of strain on the heart, on the right side of the heart. It builds up the pressure in this right side of the heart. Then because the pressure is bigger, it kind of makes that right side of the heart bigger. And then in severe cases, the right heart can become so big that it affects the left heart as well. And when the left heart occurs, that's when you get things like blood pressure problems and things like that. Echocardiogram is kind of our standard, as I mentioned, screening or even surveillance tool for figuring out whether someone has pulmonary hypertension or not. So on the right-hand side here, you'll see that this is, so LV stands for left ventricle, RV stands for right ventricle. So this is basically us looking from the outside in. This is the tip of the heart or the apex of the heart going all the way to the base of the heart. So this is kind of like, when you think of the heart, this is kind of upside down. This is kind of flipped because I feel like normal diagrams of the heart have the two atria that are sitting on top and the two ventricles sitting below. And so what you'll see here is that all of these sizes are pretty normal. And in general, the left side of the heart, because the left side sees the blood pressure from the entire body, is always a little bit bigger than the right side of the heart, because the right side of the heart only sees the pressures from the lungs. Contrast that with patient with pulmonary hypertension, and you'll see here that this right ventricle, this right side of the heart and the right atrium is either equal to or slightly bigger than the left side of the heart. And this is what's abnormal, and this is what we're looking for when we're looking at echocardiograms. Now, I mentioned that, before I get into treatment, I mentioned that, sometimes, so in scleroderma patients, we'll get into monitoring. I recommend getting a yearly ultrasound of your heart. I personally recommend my patients that if they're having symptoms, and we can't find any other cause, like their lungs look fine on CAT scan, their echo looks fine, then in those patients, I'm usually talking to Dr. Swat or Dr. Gozdecki at the University of Chicago about doing a more invasive test, a right heart catheterization, to measure the pressures in the heart to make sure that we're not missing pulmonary hypertension. All right, so, and the important thing about pulmonary hypertension is it's also treatable. So particularly in scleroderma or any other type of connective tissue disease, we tend to aim for something called treprostinil. So if the pulmonary hypertension is from the lung disease itself, this inhaler called treprostinil has been shown to improve 6-minute walk distance over time. And not just stabilize it, but improve it. So I like using, it's called Tyvaso is the brand name of this medication. So in patients who qualify, I like it because, to me, yes, the 6-minute walks are really annoying to do over and over again in clinic. I get that. But at the same time, it's like a measure of your functional capability, and that's actually improving. If you have other types of pulmonary hypertension within this, which is something that they test for when they look for the right heart catheterization, you might be a candidate for these additional therapies. Some of these are pills, some of these are IV medications. I'm not going to go into the mechanism of them in depth because we don't really have time. But in general, these medications kind of dilate that pulmonary artery and kind of help relieve that pressure that's happening on the right side of the heart. Okay. So when I'm seeing a patient in clinic with scleroderma, either with interstitial lung disease or pulmonary hypertension or other rare more manifestations of lung disease, how am I assessing for their overall disease severity and progression? What questions am I asking in clinic? So the first is patient-reported symptoms. This is always the most important thing to me. How are you feeling? How are you doing? Mainly cough, shortness of breath, chest pain. Leg swelling and abdominal fullness, again, could be signs of the right-sided heart failure that I was talking about, or pulmonary hypertension. 6-minute walk testing and ambulatory oxygen saturation. So this can help tell me when your body is, stressed. Yes, a 6-minute walk shouldn't be super stressful, but when you're undergoing some activity, how low does your oxygen go? And this can kind of help me figure out, normally your oxygen saturation might dip a little bit, but shouldn't dip more than 4%. And patients qualify for home oxygen if they desaturate below 88% on these 6-minute walk tests. Pulmonary function testing. So again, how are your lungs working? How severe is your, functional impairment and disease is really important to me. And then I follow symptoms regularly over time to help figure out, do I think this patient is stable? Do I think they're slowly progressing? Do I think they're rapidly progressing? Those each are going to have different treatment algorithms in my mind. And so, who and when to treat is an important question, not just with Scleroderma-ILD, but with all my patients. In general, if it's moderate or if the functional impairment is moderate or severe, or the disease is progressive, I treat, and I look for, again, how much inflammation versus how much scarring to figure out what kind of meds they need to be on. And then also talk about ambulatory oxygen, Pulmonary rehab, I'm a big believer in. A lot of my patients have felt a lot better with pulmonary rehab. Management of GERD, as Dr. Vignes-Warren talked about already. If it's mild and non-progressive, we have a couple of different options. Depending on the subtype of disease, we might aim to treat early, or if there's, other high-risk factors, we can aim to treat early. Otherwise, this is someone I follow in clinic. Over the first year, if someone's diagnosing, I'm monitoring their PFTs every 3 to 6 months. I might space it out if they continue to be totally stable without any symptoms and without any, change. And then I'm also, again, trying to minimize your risk factors, including things like acid reflux, other medications, other things that could be contributing, sleep disordered breathing, asking questions like that. All right. So how often am I monitoring these things? So again, pulmonary function testing. Again, this is in patients with already known lung disease. I say, every 4 to 6 months. We're at that same time, we're monitoring oxygen levels. I recommend echocardiogram yearly in most of my scleroderma patients. Chest imaging, we like to get, at least one just to see, where people are at, usually. And sometimes, some of my colleagues do every year. I tend to be a little bit less aggressive with yearly CAT scans, depending on how a patient's doing. If they're overall stable, their disease is overall mild, I don't want to get too much radiation if I don't feel like it's going to change my overall management. But in other people who are more progressive or severe or have more symptoms, I'm getting it more frequently. Vaccination is super important, things, because any type of respiratory virus in patients with interstitial lung disease can make your symptoms and your disease worse. So I'm being aggressive with, flu and COVID vaccines, as well as pneumonia and shingles as well. All right. So in conclusion, to diagnose interstitial lung disease, I'm looking at how do the lungs look on CT scan? How do they work on pulmonary function tests? We have effective therapies in the form of anti-inflammatory medications, immunosuppressive medications, and anti-fibrotic medications. And I'm monitoring them both with these functional and radiologic outcomes. For pulmonary hypertension, you can diagnose it either with the echocardiogram or the right heart catheterization. We have therapies that aim at dilating those blood vessels and removing as much strain on the heart. And I do recommend monitoring with an echocardiogram every 12 months. All right, with that, thank you. I'd like to acknowledge the rest of my interstitial lung disease group. Dr. Mary Strack is our head of our interstitial lung disease program. Dr. Adeg Soy is our scientific director. We're all seeing patients, so if you're more than welcome to come or have friends or family come. And then Dr. Michael Macklin, who you'll hear from in a bit, is the director for our scleroderma program. And there's my email. Feel free to email me with anything. I'm a millennial. I check it too much. All right. All right.